Hi there, I'm Rebecca. I'm one of the clinical research fellows working at the Golden Jubilee, undertaking a PhD at the University of Glasgow. And I'm going to present my systematic review on risk assessment tools for predicting complications after emergency laparotomy, which was recently presented at the WASA event. So complications after emergency laparotomy are extremely common. Major complications occur in almost half of all patients. And you can see by the survival analysis graph here that that's directly related to mortality. Now, NICE recommends that we try and quantify this morbidity, which will allow for discussion for perioperative care and anticipated clinical course. But can we actually predict complications? There's only one review currently published regarding risk assessment tools and their use for predicting complications, which was published by NICE in 2020. And that showed that the scoring systems which performed well or moderately well in predicting complications and morbidity were POSSUM, EPAS, and the NSQIP score. And right there is their C statistics, or the area under the curve, otherwise known as their discrimination metrics. Unfortunately, in this review, it included all types of surgeries. Morbidity was a composite outcome, so it wasn't specific to complications, and all of the studies included were of a very low quality. There's no other systematic review, comprehensive systematic review out there which looks at risk assessment tools and their ability to predict complications after emergency laparotomy itself. So our aims were to identify which risk assessment tools are currently used and to identify the performance of them for complications after emergency laparotomy using statistical metrics. The definition that we took for risk assessment tools was a multivariable tool that combines two or more predictors to estimate the probability of risk for a specific defined future event. Importantly, we made two exemptions to this rule. ASA was not included because it's a subjective assessment rather than a true predictor of an outcome, and all frailty scores were excluded. There has previously been a systematic review looking at frailty scores and their relation to outcomes after emergency laparotomy, so this is already done. Plus, most are developed and actually only validated for patients who are over the age of 65, which might not be applicable to our entire emergency laparotomy cohort. And finally, frailty scores are often incorporated into existing risk assessment tools anyway, such as the NSQIP tool and the emergency surgery score. So we conducted a systematic review registered on Prospero. We followed the PRISMA guidelines, amongst others, for prognostic studies, and we searched 4 major databases. We included adults who underwent an emergency laparotomy for a GI pathology, so we excluded trauma laparotomies because their physiology is very different, and we also excluded gynecology, urology, and vascular laparotomies. We excluded randomized controlled trials, case reports, protocols, and we also excluded papers which reported our morbidity as ICU length of stay or length of stay. So the paper had to have one complication at least after an emergency laparotomy to be included. From this, we found almost 6,000 papers, and we ended up including 23 of them. The sample size was very variable, as was the geographical distribution of the papers, and actually 5 were from Europe and only 1 was from the UK. Most were retrospective single-centre studies, and a lot of them reported their model performance metrics incompletely, for example, not reporting their confidence intervals. Some looked at all complications as their primary outcome, and some looked at only some specific individual complications. Overall, there was a low risk of bias and 43% and good applicability in 35%. So we found 14 risk assessment tools across the 23 studies, but there was significant heterogeneity in reporting of these and in methodology. For example, some studies defined complications as the NSQIP definition, some used Clavi and Dindo, and some didn't specify at all. Some studies used follow-up for until discharge and some until 30 days, and some even longer than that, and again, others didn't specify. In terms of their calibration metrics that were reported, 8 studies included these, but they were again very variable, some using observed to expected ratios, others using Breyer scores, and you can see in this graph here the frequency of the type of calibration metric that was used. Because of the heterogeneity, we were unable to pull any analysis here and draw any truly meaningful conclusions. Discrimination was more prevalent, so 15 studies in total reported discrimination metrics, which is area under the curve or C statistic. 11 of these studies looked at the discrimination metrics for all complications. And as you can see here, Apache and Possum, for example, are commonly used in the UK, but NSQIP, emergency surgery score, and Potter are all far more commonly used in America. The emergency surgery score was the most commonly reported score, and we were able to do a small meta-analysis of 3 studies which were similar. This showed that the emergency surgery score predicts all complications with a C statistic of 0.77%, which is moderately good, and we take 0.8 as very good predictability. For the individual complications, you can see the ones that were gathered on the x-axis here, and on the y-axis is the scoring systems which were used to predict them. 8 studies included this information, and for each of the boxes in this graph, the darker the colour, the better the predictability of the score. So for example, the Potter score predicted prolonged mechanical ventilation with a C statistic of 0.91%. We were able to do a meta-analysis for the Potter score and for the emergency surgery score for certain complications. Septic shock, pneumonia, and prolonged ventilation all scored highly on pooled analysis for the Potter score. For the emergency surgery score, that predicted ITU admission with a C statistic of 0.79, so just falling short of the 0.8, but still good. So to take home then, of the 14 risk assessment tools that we found across our 23 studies, meta-analysis was actually only possible for the Potter score and for the emergency surgery score because of significant heterogeneity. And as I said, these are less commonly used in the UK and Europe. The analysis was significantly limited because of the variable outcomes. So no single risk predicting model can currently be recommended for predicting complications after emergency laparotomy. Our next steps are going to be finding out how this applies to a UK cohort. None of these scores, the Potter and emergency surgery score, have been validated on a UK cohort at predicting complications. And then after that, to see whether that compares to something that we use very commonly, NELA, and then frailty. Thank you very much for watching along, and happy to be contacted by anyone for further questions and further information.